introduce my friend and colleague, Dr. Mustafa Barber, who will be the grand round speaker today. Dr. Barber, as you know, is the co-director of Neuro-Oncology program here at the Norton Children's Cancer Institute, and he's also the fellowship director. Dr. Barber was born and grew up in Syria. He gained medical degree from the University of Damascus in 2004. He completed pediatric residency at University of Louisville from 2005 to 2008, and a pediatric hematology oncology fellowship at Penn State University from 2008 to 2011. His first faculty position was at University of South Dakota Sanford School of Medicine from 2011 to 2015. That is when his interest in neuro-oncology started. He returned to Penn State University in 2015 and continued to focus on pediatric neuro-oncology. And he returned to Louisville in 2017, which he calls home. As you all know, childhood cancer is often regarded as a success story. That is because the most common childhood cancer, acute lymphoblastic leukemia, if a child was diagnosed in the 60s, there was less than 10% chance of survival. Fast forward to 2021, now greater than 95% of children with acute lymphoblastic leukemia survive. This has largely come through research. But we should still keep in mind that childhood cancer still remains the leading cause of death due to disease. In 2016, the CDC announced that the leading cause of death due to cancer was no more acute lymphoblastic leukemia, and it was brain cancer. So to see how far we have come in the field of pediatric brain cancers and how far we have to go today, Dr. Barber will present his grand round presentation. So please join me in extending a warm welcome to Dr. Barber.
Thank you, Dr. Raj, for the kind introduction. I do not have any conflicts of interest to declare. Objectives for today's talk are the following. Review early days of brain tumor, diagnosis, treatment, and classification. And then we will move on to review early days of pediatric neuro-oncology. And that will be the main focus of the first half of the presentation. And then we will move on to review common pediatric brain tumors, where we are now, and then review recent advances and future directions for common pediatric brain tumors. Brain tumors are the most common solid tumors in childhood, and they are estimated to be anywhere from 20 to 25% of all childhood cancers. They are heterogeneous, too many different types and many subtypes. As Dr. Raj mentioned in his introduction, childhood brain tumors are the most common cause of cancer-related mortality and morbidity in childhood. The 5-year overall survival is approximately 75%, and that is compared to around 83% when you take all types of pediatric tumors combined. Treating childhood brain tumors is commonly associated with long-term sequelae, and they are often significant sequelae. We cannot talk about the field of pediatric neuro-oncology without talking about challenges. And this was a very common slide that was presented when I was a fellow, talking about all of the challenges and the reasons why treating brain tumors was, in general, less successful compared to other malignancies. And we always talk about large number of different tumors. Heterogeneity is very common among tumors with the same morphology. Many of these tumors are rare, Many of them like to present in locations that are very tricky for the surgeons to go after, and thus they behave like malignant ones. And again, cure often entails significant long-term sequelae. And until recently, we had very limited understanding of the biology of CNS tumors. So we'll start the talk by reviewing the past. And I divided the early days into 4 different fields, if you would: neurosurgery, radiation therapy, chemotherapy, and neuroradiology. Starting with early days of neurosurgery, skull trepanation was done a long time ago. It was mostly performed for trauma. Great ancient physicians like Hippocrates, Socrates, and many others left very clear instructions on how to do trepanation to alleviate increased intracranial pressure. There is no mention of brain tumors in their writing. In the New World, the Incas were really good neurosurgeons, apparently, and they did not only use trepanation, but they also did successful craniotomies. And there was no documentation, or there is no known documentation of brain tumor resections. I took these pictures from an article that was published in Neurosurgery reviewing Inca's craniotomies and cranioplasties. And on the left side of the screen, you see a skull of somebody who underwent cranioplasty with gold plate with what looks like really good bone healing. And on the right side of the screen, you see different instruments that they used. The first surgery to remove a brain tumor was reported in 1879. William Mason performed a successful brain tumor removal in a young woman. He localized the tumor by clinical examination, and he reported removing what he called the usual fungus tumor of the dura mater. And based on his descriptions, that tumor was most likely a meningioma. When you read about early days of neurosurgery, two names will come up over and over again: Dr. Harvey Cushing and Dr. Bailey. Dr. Cushing started at Johns Hopkins, and then he moved to Boston in 1912. Dr. Bailey started in Chicago, and then he wrote to Dr. Cushing, and then he joined him in Boston in 1919. And they both spent almost 10 years together working as clinicians, as researchers, and their partnership produced many breakthroughs in the field of neurosurgery. And they published the first classification of brain tumors in their book in 1926. And in this diagram, you see their classification, which honestly, it's hard for me to make sense of the classification, but in 1926, this was the very first serious attempt to classify brain tumors. Before their book, most of the brain tumors were just called gliomas. During the first quarter of the 20th century, many advances took place in the field of surgery in general, and especially in neurosurgery. Adoption of new anesthetic methods, introduction of techniques like motor-driven suction for brain tumors, and electrosurgical devices took place. And by 1930, Dr. Cushing had operated on over 60 cases of medulloblastoma, and he described medulloblastoma in an article in 1932, and he was the one who gave medulloblastoma its name. I believe it used to be called spongioblastoma before then. And one of it's very interesting to read that history, because one of Dr. Cushing's patients with medulloblastoma survived for more than 5 years. He had the first surgery followed by radiation, then he had a second surgery for local recurrence, a third surgery for another local recurrence, and then the child passed over 5 years after diagnosis because of spinal metastatic disease. We will now review early days of radiation oncology. This picture is the cover of the Life magazine in 1958, and it talks about radiation oncology as a new hope for cancer patients. X-ray was first discovered in 1895, and shortly after it was discovered, people started using it to treat cancer. Many of the early radiologists used their skin to test their devices and measure the dose. They called it erythema dose. And essentially the theory was that if your device is able to produce a radiation dose that's significant enough to irritate your skin, that's an appropriate treatment fraction. And unfortunately, we learned the hard way because of their hard work that radiation does not only treat cancer, but it can cause it, because many of the early radiologists developed leukemia. By the 1950s, that's when radiation oncology became one of the new treatments for brain tumors. There was a landmark study that was published in 1953, which demonstrated for the first time that craniospinal irradiation dramatically improved survival for children with medulloblastoma. The cure rate in that study well, not the cure rate, but the survival for over 3 years in that study was estimated to be around 60%. In the 1960s, that's when modern craniospinal fractionated irradiation with posterior fossa boost was used for posterior fossa tumors like medulloblastoma and ependymoma. Again, it was quickly discovered that the survival benefit from radiation was there, but there was also significant morbidities, especially for the younger group of children. And those morbidities can be neurocognitive, can be malignancies, or endocrine dysfunction. And a lot of this had a combination of all of these morbidities. And by 1970s, the field started looking into ways to decreasing radiation and improving outcome. And that's when adjuvant chemotherapy was considered to be, one way to achieve that goal. This is a picture of Dr. Farber's article in the New England Journal of Medicine. And he summarized the very first time chemotherapy was used for cancer. He used what we now call methotrexate to treat 5 children with acute lymphoblastic leukemia. So in 1946, the structure of folic acid was discovered, and folic acid back then was used to treat different things, including leukemia, and Dr. Farber observed that folic acid accelerated the leukemic process. So he asked Lidl labs to synthesize what he called an antifolate, and they produced many analogs, and methotrexate was the best tolerated. And in his first small study, the methotrexate produced around 40% remission rate. It did increase median survival, but all kids then recurred and became unresponsive to methotrexate. For pediatric brain tumors in the 1970s, that's when randomized trials started, and the focus was on assessing efficacy of chemotherapy in addition to radiation therapy. So randomized trials looked at chemotherapy or no chemotherapy after radiation therapy for medulloblastoma, malignant glioma, and brainstem gliomas. And those studies showed that there is a benefit in medulloblastoma, not necessarily in malignant gliomas or brainstem gliomas. The outcome was still poor. As you see, the European trial showed overall survival of only 38%, and the North American trial back in the 70s with surgery, chemo, and radiation, the event-free survival was only 32%. Early days of neuroradiology. The field of radiology really started in 1895 with the discovery of the X-ray in the 1900s. In the early 1900s, X-ray was used for diagnosis of brain tumors, especially for the tumors that change the contours of the skull or the ones who had osseous deposits, which made them visible on X-ray. In 1918, a new technology using X-ray was pioneered by Dr. Dandy. It's called ventriculography. And what it is, essentially, it is injection of air into the ventricles, and that will make the ventricles visible on the X-ray. And you get something similar to this. So in this patient, you see the patient has a tumor on the left side in the anterior part of the brain. So on the PA view, there is no problem. On the right, there is opacity, let's call it, in front of the left lateral ventricle, and that's how they localize the tumor to the anterior part of the left side of the brain. In the 1940s, people started using angiography to diagnose brain tumors. And in this picture, angiography was used to diagnose glioblastoma multiforme in an adult patient. Nuclear scanning for brain tumors started in the 1940s. It was pioneered by a surgeon in Minneapolis, Dr. Moore. He began by injecting fluorescein to outline tumors during surgery, and later on he tagged fluorescein with radioactive iodine, and that allowed visualization of the tumor before surgery. The first report of use of nuclear scanning was published in 1954, and it showed that there is accurate localization in a little bit less than half of the patients, so certainly not good enough. And this is an example of nuclear scanning for localization of a brain tumor. More recently, in 1971, CT scan, a head-only CT scanner was installed in London. That was the very first, and shortly after that, another one was installed at Mayo Clinic. And by 1975, use of contrast was introduced, and the first whole-body CT scanner was developed. In the 1970s, many articles discussed use of CT for brain tumors, and by 1980, only 9 years after it was first used, CT scan became the most accurate diagnostic tool to diagnose brain tumors. MRI was first used in 1977. By 1984, publications started discussing use of MRI for brain tumors. And in 1985, the first article with focus on pediatric brain tumors was published. Gadolinium use was introduced for tumor enhancement and other things. And development of diffusion-weighted imaging was very helpful. For the next few slides, I will be reviewing the early days of pediatric neuro-oncology. The field certainly started before 1980, but the kind of organized effort to improve outcome for patients started in the 1980s. And in the 1980s, the pediatric neuro-oncology field was looked at as a depressing field. Most of the children with brain tumors died. The few that survived experienced poor quality of life. A small number of oncologists were interested in the field. However, a few studies took place. In 1985, there was randomized trials looking at chemotherapy for high-grade glioma and medulloblastoma. By 1989, a new combination regimen using vincristine and carboplatin for young children with low-grade gliomas was developed. And it is actually continues to be considered the standard of care until our days. In the 1990s, more research activities took place. A new post-irradiation chemotherapy regimen was introduced for children with newly diagnosed medulloblastoma. It successfully reduced craniospinal radiation, and that regimen continues to be considered the standard of care for good risk patients. In the 1990s, most of the studies relied on CT scan for staging. MRI was not widely available back then. And in the 1990s, first studies of bone marrow ablative chemotherapy were done for childhood recurrent malignant brain tumors. One unique study that took place in the 1990s was Head Start 1 trial. It was an attempt to avoid radiation for children with malignant brain tumors that are very young. And these very young children were the kids who did have the worst long-term sequelae after radiation chemotherapy. So this study looked at using very intense induction chemotherapy followed by a single cycle marrow ablative chemotherapy. In the 2000s, clinical trials continued with main goals to decrease exposure to radiation and to try to avoid or limit radiation exposure in the younger group of children, and to improve outcome for aggressive tumors like diffuse intrinsic pontine glioma and high-grade glioma. There was minimal to no improvement in outcome in most cases. One important thing that took place in 2003 was completion of the Human Genome Project. And that was the beginning of the molecular era, which influenced the field of pediatric neuro-oncology, just like it influenced pretty much all different medical fields. By 2008, 2009, studies started to identify recurrent molecular alteration in different brain tumors, both adults and pediatric brain tumors. And by 2010, molecular analysis of brain tumor became more and more important, and different studies both in Europe and North America took place evaluating different pediatric tumors. So the last 10 years, did provide a lot of molecular data, and the molecular data became significant enough that the World Health Organization classification was updated in 2016 to incorporate some of the molecular classification of different tumors. And before I move on to talk about the relatively common brain tumors, just want to review a simplified CNS tumor classification. So we divide CNS tumors into intrinsic and extrinsic. The intrinsic are the more common ones, and they are divided into embryonal or neural and non-embryonal. And the non-embryonal are glial or choroid plexus tumors. And again, many different types of tumors. Gliomas are both low grade and high grade are the most commonly seen tumor in pediatric neuro-oncology. That's followed by medulloblastoma and ependymoma. So for the rest of the talk today, I'm going to focus on astrocytoma, ependymoma, and medulloblastoma. Starting with low-grade glioma. It represents multiple tumor subtypes. It is the most common pediatric tumor of childhood. And an important group of patients is a group of patients with neurofibromatosis type 1. Approximately 20% of all patients with NF1 develop an optic pathway glioma. And the current treatment decisions are based on tumor location, age at diagnosis, and to a lesser degree, tumor biology. The children with low-grade gliomas, most of them will undergo surgical resection. Sometimes that's not possible and only biopsy is feasible, but the majority will undergo complete or near complete surgical resection, and that's usually followed by observation. For children who have tumors that are partly resected or only biopsied, usually we follow surgery with chemotherapy, and depending on their age, if they are older than 15, typically we would consider radiation therapy, although we try to delay that in general. Children with NF1 and optic pathway glioma are treated differently. Usually biopsy is not needed. The diagnosis is made based on MRI findings, and because they are at high risk for secondary malignancies, we usually avoid radiation and alkylating chemotherapy. Their outcome is certainly suboptimal. Around 50% of the patients will have no recurrence of their tumors. The other half will be dealing with almost a chronic disease. So their tumor will be active on and off for the rest of their lives sometimes, and they need multiple courses of treatment. The Kaplan-Meier diagram on the right side is from one of the recent clinical trials looking at two different chemo regimens for low-grade gliomas that are incompletely resected or recurring, and the cure rate is just below 50%. In general, the 10 to 20 year overall survival for children with low-grade glioma is approximately 90%. The majority of pediatric low-grade gliomas are driven by a single genetic alteration. Most of the time, it's in the MAP kinase pathway. Two distinct gene alteration involves a BRAF gene. One of them is the KIA 1949 BRAF gene fusion, and the other is a point mutation, BRAF V600E mutation. Both of them, they lead to activation of the downstream MYC, ERK, and then that leads to cell proliferation. And NF1 patients, there is lack of inhibition of RAS, and the result of that is, again, upregulation of downstream MYC and ERK. MYC1, MYC2 inhibitors are available, and they have been studied for low-grade gliomas. These graphs are from a recent phase 2 trial that looked at silumetinib, which is a MYC1, MYC2 inhibitor. Response to treatment was comparable to traditional chemotherapy, depending on the genetic alteration. Patients who had the BRAF fusion in blue did better than children who had the BRAF mutation. But in general, if you look at the waterfall graph on the right side of the screen, it is noticeable that the majority of the children did have shrinkage of their tumor. And the way this graph works is that this is the size of the tumor at baseline, and then each of these bars represent a patient. So the first 4 patients did have continued tumor growth on treatment. All the other patients did have a decrease in size, and a good number of them had more than 50% decrease in the size of their tumor. For stratum 3, which enrolled NF1 patients, all patients had decrease in size of their tumor, and again, a good number of them had more than 50% decrease in size. So based on these data, now at the Children's Oncology Group, we have 2 ongoing controlled randomized trials looking at silumetinib for upfront treatment for low-grade gliomas. The first study is for patients with NF1 associated low-grade gliomas, and it randomizes patients to receive carboplatin vincristine for 14 months or silumetinib, which is an oral medicine, twice-a-day oral medicine for a total of 2 years. A similar type of study is ongoing for patients who do not have NF1 and who do not have BRAF mutation. So mostly the patients who have BRAF fusion, and it's also randomizing them to receive either carboplatin vincristine or silumetinib. And this trial is really important because I think durability of the response is very important, and it would be important to see how will the patients who receive silumetinib do long-term after end of treatment. High-grade glioma and diffuse intrinsic pontine glioma are the topic of the next few slides. DIPG and GBM are relatively common. DIPG represents about 10% of pediatric brain tumors. High-grade glioma, anywhere between 10 to 15% of pediatric brain tumors. So between the two of them, they represent close to 25% of what we see. And the outcome remains to be very poor and has been virtually unchanged for a long time. The current treatment is radiation therapy, which does provide some disease control for short, relatively speaking, short term, just months, rarely years, plus minus chemotherapy. In the early 2010s, publications started coming, reviewing different and distinct subgroups of high-grade gliomas. Studies describe 6 subgroups. 5 of them are seen in children. In children, the most common mutations are in the histone H3.1 and H3.3 genes. We call them K27M mutation, and mutations in receptor tyrosine kinase 1 are common as well. There is a unique subgroup of patients. We call them PXA-like. Essentially, they look really ugly and high grade under the microscope. If you do methylation profiling, they resemble a lower grade tumor called pleomorphic xanthoastrocytoma. And they frequently have BRAF V600E mutation, and they have favorable outcome. And this figure, it's a good summary of these 6 different types of high-grade gliomas. And this is the most common type we see. And again, the K27M mutation is very aggressive. The approximate median survival is around 6 months, and it is seen mostly in the younger group of patients, and it does tend to happen at midline. So if you take DIPG for an example for high-grade gliomas, 70 to 80% of patients with DIPGs, they do have K27M mutation. And what happens when the K27M is mutated, that will suppress trimethylation of the K27, and that will leave the chromatin open. And the result of that is a very aggressive tumor in the pontine, in the pons. And that influences the outcome. The outcome is poor for these kids. Regardless of K27M status, they are still aggressive tumor, but the patient who have K27M mutation have significantly worse outcome, as represented here with the red line, as the majority of them will survive just for a year or 2. Very few will survive beyond that. The patient who have wild type K27 or wild type histone 3, they do have longer survival. So it did appear, based on all of these studies, that the driver in pediatric high-grade glioma biology is really disruption of the epigenetic regulation, histone modification, DNA methylation, and chromatin remodeling. And that modifying, histone and DNA methylation has been the focus of a lot of the ongoing early phase clinical trials for pediatric high-grade gliomas. Moving on to talk about medulloblastoma. It is one of the most common malignant brain tumors. Peak age is approximately 4 to 5 years. Current treatment is maximal safe resection followed by radiation therapy with concurrent chemotherapy, and we do radiation to the brain and spine, and that is usually followed by maintenance chemotherapy. the overall long-term survival is 60 to 70%. Unfortunately, most of the survivors do experience significant long-term morbidities. The clinical risk groups are three. So we have the standard risk. These are patients who are usually older than 3, and they have no evidence of tumor spread at diagnosis, and they have complete surgical resection of their tumor, and their cure rate is about 80%. The higher risk group, these are patients who have evidence of spread, so they have metastatic disease, or they have incomplete resection or combination of both. The cure rate for this group is about 50%. And then the third distinct group of patients is the younger group of patients, the patients who are younger than 3 years. And for these patients, we try really hard to avoid radiation therapy, and their cure rate is approximately 50%. More recently, medulloblastoma is classified into different subgroups based on the molecular changes we see, and the 4 core molecular subgroups are wingless or Wnt activated, sonic hedgehog activated, and then group 3 and group 4. And these 4 groups are defined by unique clinical behavior and outcome. And in this table, there's just a summary of these 4 subgroups. The best outcome is seen in Wnt. It's favorable. Unfortunately, only 10% of our patients have Wnt. Their survival is more than 90%, and they are rarely metastatic. For sonic hedgehog, these are slightly more aggressive tumor, but they can be favorable. And the key thing in these patients is the TP53 status. So if it is TP53 mutated, their outcome is very poor. If they're P53 with wild type, their outcome is closer to 75 or 80% cure rate. Group 3 is the most aggressive. It represents about 25% of all medulloblastomas. The outcome is only 50% cure rate long-term, and they are commonly metastatic at presentation. Group 4, it is the most common group. Significant percent of children, they present with metastatic disease, but they are more responsive to treatment compared to group 3, and their outcome is better. Their cure rate is about 75%. And we are currently not necessarily standard of care yet, but more and more we are using these subgroups to risk stratify. So we look at stage of disease, metastatic versus non-metastatic, and degree of resection, and we also look at the molecular subgroup, and we factor in the molecular subgroup into the risk stratification and the type of treatment that a given child will receive. Then we'll talk about ependymoma. Ependymoma is mostly an early childhood malignancy. Approximately 50% of cases occur within the first 3 years of life. Most of the time, 2/3 of the patients have tumors in the posterior fossa, and 1/3 have tumors in the supratentorial region. An outcome for children, especially infants, is relatively poor. The long-term survival for infants, and again, infants in pediatric neuro-oncology is younger than 3 years, is approximately 50%. Current treatment for ependymoma, surgical resection is very important. The event-free survival is influenced very significantly by the degree of resection. Children who have completely resected tumor, they have long-term survival of 70 to 80% versus children who have incomplete resection. Their long-term survival is closer to 41%. Focal radiation does improve local control of the disease. Chemotherapy role is debatable. Based on the most recent children's oncology group trial looking at adding maintenance chemotherapy after surgery and radiation, it does look like chemotherapy improves outcome for patients with complete resection, not for patients who has incomplete resection. It is relatively early to use molecular data to guide treatment of these children, and clinical trials are needed. These are the 4 molecular subtypes or subgroups of ependymoma based on the location. Supratentorial, the first 2, or posterior fossa, the last 2. So in the supratentorial region, they are divided into real effusion. These are more aggressive tumors. Again, they tend to happen in the supratentorial area, and the outcome is relatively poor. And they happen in older kids typically and adults. Supratentorial YAP1 ependymomas occur in younger children and or younger patients, mostly children, and has excellent long-term outcome. Posterior fossa, group A, it occur mostly in the infants group. It's usually again posterior fossa, and the outcome is relatively poor, about 50%. Posterior fossa, group B, is seen mostly in teenagers and adults, and has an excellent outcome as well. For the last few slides, I would like to focus on the future of the field and what we are doing in Kentucky to improve the care we provide to the children with pediatric brain tumors. So I believe that the biggest challenge we have in the field is trying to make use of all of the accumulating molecular data. Molecular data keeps on coming, and the more data we have, I feel that the more confused we become. So using the molecular data we have to better classify CNS tumors is crucial, and also using the data to risk stratify and treat these patients is needed. We need new molecular targeted therapies to target some of these alterations that we discovered, and maybe some of these groups will be appropriate to try immunotherapy for. And for the available targeted therapies, I believe that we need to assess durability of response. It's good to see that these tumors are shrinking and sometimes disappearing on targeted therapies, but for how long the tumor will be controlled, that needs to be determined. And this is an example of heterogeneity, and why I said that the molecular data can sometimes make it even harder to decide about appropriate treatment. We used to talk about 4 different medulloblastoma subgroups. Now, in this publication, they divided the patients into 12 subgroups, and some research did show, based on methylation profiling, that group 3 and group 4 could be divided into anywhere from 8 to 16 different subtypes. So here in Kentucky, the good news is that pediatric cancer in general is rare. Less than 1% of all cancers diagnosed in Kentucky are pediatric cancers. The bad news is that incidence rates have increased approximately 2.5% annually between 2008 and 2017, as it's shown in this graph. Rates of CNS tumors are significantly higher in Kentucky compared to the United States. And we simply do not know why. We do know that this has been the case for at least the last 20 years. Brain tumors in Kentucky, as shown in this graph here, are statistically significantly more common in Kentucky compared to the rest of the country. Leukemia in Kentucky is actually a little bit less common than the rest of the country, and we do not know why. So right now, we have a collaboration between our institution and University of Kentucky. That collaboration is funded by Kentucky Pediatric Cancer Research Trust Fund grant, and our objectives are to do next generation sequencing and germline testing for our patients with brain tumors treated in Kentucky. We implemented a pediatric molecular tumor board, and we're creating a statewide population-based registry, and that study has an optional tumor banking component for to use tissue for future research. The project has just started, so I do not have any significant data to share with you, but this is an example of the next generation sequencing reports we get when we do molecular profiling. So we get information on significant and actionable genetic alteration. If we send a blood sample, typically we would get information on potential germline mutations. We receive information on immunotherapy markers like tumor mutational burden and microsatellite instability status. And then they will suggest potential treatments, like for this patient, pembrolizumab or the PI3 kinase inhibitor. And before I end my talk, I'm almost done. I wanted to share with you a quote from Dr. Jonathan Finley. Dr. Jonathan Finley is one of the pioneers in the field of pediatric neuro-oncology. He retired this past summer, and he sent an email to the community. And in that email, he said, 40 years later, I am stepping back from the field of pediatric neuro-oncology, proud of what we as a community have achieved, but acutely aware of how much we have yet to improve, both nationally as well as globally. And before I end, I just want to thank our team, our pediatric neuro-oncology team. And I want to thank you all for listening to my talk. This is just a picture of one of my patients. Very thankful to my patients and their families for their trust. They are indeed the most brave people I know. Thank you.
Mustafa, can I ask a question?
Yes, sure.
Hi, it's Esther.
Hi.
I'm excited about your study. Are you guys going to try to collect data that might shed some light on why the incidence of brain tumors is higher in Kentucky and particularly certain regions?
That's really one of the main objectives of the talk. I'm sorry, not the talk, the project. I'm sorry, I'm just trying to figure out the screen in front of me. But yes, I mean, that's what the data from the cancer registry, from Kentucky Cancer Registry, is what triggered this collaboration and our attempt to figure out, why our patients are more likely. It would be much easier to, study potential, germline mutations and looking at things like, environmental exposures. Although that's important, but I think trying to see if there are recurring genetic alteration in our population would be very interesting.
Okay, yeah. So you'll be collecting data about germline variants and less so environmental factors or demographic factors.
Right. So germline testing is optional, of course, on study. And then we're collecting blood samples as well for essentially liquid biopsies. And we would be collecting tissue for future research. So some of this is going to be optional.
Okay, yeah, sounds really interesting.
One question I received in the chat is, what counties in Kentucky are most affected? It does seem that the Appalachian region is more affected than the western part of the state. And I do not, that report was very detailed, and I believe it did look county by county, but I did not look that close at it. But in the Appalachian region in general is more, the brain tumors are more common. One question from Dr. Orman, how long does it take to get the molecular genetics back? It has been taking about 2 to 3 weeks to receive it back.
All right, everyone, thanks for joining us today. If you have any further questions, Dr. Barber has included his email in the chat. But with that, we will conclude Grand Rounds.